reduction, improving health among people who use drugs. So the big question first is just what is harm reduction? And keeping it sort of too simple, in my mind, it's sort of akin to using safe sex. You can tell teenagers or anybody else that you should remain abstinent and not be sexually active until you're with one person forever. But you know that that's really not going to work, and that they're going to go out and be sexually involved anyway. And if they're not practicing safe sex, they could end up with a sexually transmitted infection, an STI, or even end up dead. And that's sort of a high price to pay. So instead of saying stay abstinent, we say, well, do what you can to engage in sex safely. And that means using condoms and knowing who you're with and things like that. Well, that's what harm reduction is. It's telling people not stay abstinent forever, because that just doesn't work for most people, but rather, well, if you are going to use substances, then you should be able to use them in a manner that allows you to use them safely. And that's what harm reduction is. We know that it's sort of a hopeless endeavor to tell people just abstain. So instead, what we do is tell them what they can do to use substances more safely. And that's what we'll be looking at today. Does that make sense to everybody? And Joe, Joe, can you hear me? Joanna?
Yes, I can. Sorry, I was on mute.
Okay. So in the group chat, we have a whole pile of messages that say the pre-test link did not work.
Okay, so just don't worry about that, guys. Just don't worry about it.
Okay, just wanted you to know that. See, I'm paying attention.
Yep.
Okay, so, and I do have no relevant financial considerations to disclose, just a little bit about me since I found out about you guys already. I had been a professor of psychology at Rick for 43 years, up until this past spring, yay. And during that time, 19 of those years, I was director of the Chemical Dependency Addiction Studies program. During that time as well, for 30 of those years, I was a registered nurse in the neonatal intensive care unit at Women and Infants. So I've kind of got the dual background. And just as a sort of other aside, and my specialty in psychology was teaching the course in adulthood and aging. So kind of looked at the spectrum all the way from newborns all the way up to elderly. And obviously the substance use issue hits at all levels. Go ahead, Joe. So a patient comes in for treatment to address depression. They've been self-medicating with opioids. How does that make people feel? What emotions does that generate in any of you? And just shout out at this point if you're awake.
Concerned.
Okay, concerned is a very definite good way to feel. Anything else? Does this make anybody else angry or sad or depressed or empathetic? Now, all of those are sort of reasonable emotions. And the question then is, why do we feel the way that we feel, however that is? And you can go to the next slide, Joe. And the answer to that is multiple fold, that it can be based on your private life, your own personal experiences with family, with friends, with relationships that you've been involved with. It can be a result of your professional training and the support that you get. It can be a function of where you work and the policies where you work, or previous experience that you've had with patients. Now, all of these things are going to make a difference. We're going to look at a video now, sorry, that deals with a person who is a substance user, and she makes the case, or will make the case, that substance use has such a stigma attached to it that it prevents her from getting a lot of the help that she needs. And that's one of the things that we can do to reduce harm, is to reduce that stigma. So go ahead, Joe.
From everybody, I wouldn't go to the hospital just because I knew that as soon as I got there, as soon as they looked in my chart and saw that I had a history of heroin addiction or saw the abscess in my arm, I was instantly labeled a junkie. I was left in the hallway for hours, asking for a glass of water. I'd be ignored for hours. Even when I went there for something that had nothing to do with pain and I wasn't requesting pain medication, they would automatically think that's why I was there and tell me that before I even said anything, don't think you're getting any narcotics from us, you know. And it's debilitating. It kept me from, for a long time anyway, from getting treatment. You know, I was afraid that everybody would think I was a junkie and a disgusting, dirty person. You know, that language, clean or dirty, or, you know, even the word addict has so many, you know, connotations to it that it's just, it's sad, and it's killing people. It's literally killing people because it perpetuates the stigma and it prevents people from getting treatment.
So here you can see that one thing that we can do is indeed change the language that we use and help to decrease the stigma to allow people to have better access to care. Go ahead, Joe. Whoops. We don't want to see Stephanie again, even though she was a nice girl. Okay, so what we're going to do now is look at different harm reduction strategies that can be used for that can be used with patients who are substance users. We are going to talk about person-centered language to reduce the stigma in dealing with patients who use drugs. And we'll look at the difference between substance use and substance use disorder, which actually has changed over the last decade or so, courtesy of the change from DSM-4 to DSM-5, but we'll see that in a while. We're going to look long and hard at the language that's used in the care of person who's used substances, hoping that it will make a big difference in terms of stigma and come to understand the difference between substance use and substance use disorders. So let's start out by looking at what harm reduction is. And it's a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Kind of what I said before, akin to safe sex. That basically it's an evidence-based practice that we find really does work. It involves keeping the patient, the client, as a part of the treatment plan, meeting them where they are, not leaving them behind, giving them and maintaining their recovery capital. Is that a term that people are familiar with? Anybody not familiar with recovery capital? Does no answer mean you're all familiar with it, or yeah, all mute? Anybody? You are still out there, right? I hate this when everybody's on mute. All right, so getting no answers, we'll assume that maybe I should say what recovery capital is. So recovery capital basically are the resources that are available to people who are in recovery. It may be family, it may be friends, it may be treatment programs. It's anything that people can rely on to help them in their recovery. And we're going to try and address the underlying issues that drive the substance use disorder. And there are a lot of underlying issues. Go ahead. So what harm reduction does not do, and this is a big problem because I can remember when my daughter was in elementary school and they wanted to, and that was 30 years ago, They wanted people to come in and talk to the Parents Association about either safe sex or avoiding substance use. And the parents were all like, no, 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 because if we talk about it, we're enabling them. And that's ridiculous. Telling people what's available out there and how to use what's available out there more safely is certainly not enabling them. We're not telling them that all you can do is abstain. We're not telling them that all substance use is a problem. If you're on meds for anxiety disorders, if you're on opioids after surgery, then that would not be considered problematic. And harm reduction is not us deciding what's best for the client. It's us deciding with the client what's best for the client. Joe? So, Rhode Island Psychological Association, which some of you are aware of, attempts to promote the general welfare of individuals, families, groups, and societies as a whole. They promote psychological research and try to develop principles based on evidence-based practice. One such principle is harm reduction. And they try to use these principles, including harm reduction, to treat the diverse population of the state of Rhode Island. Joe? So, as psychologists, we listen to and help people to deal with their problems. We help to see people, and this goes for psychologists, social workers, nurses, any of the above. We help people to deal with stressful situations. We help them to recognize their feelings and think about new ways to deal with them. Okay, we recognize that, whoa, we're jumping around, and Joe, the slide is covered there.
I'm sorry, it's
Yeah,
sorry about that.
Well, I'm okay, but I don't know if they're okay. So they help people to recognize their feelings and think about new ways to deal with them. Yes, I recognize that you're angry, but is that a reasonable response? And is it the best response that you could come up with? Are there other things that we could do that might be better enabling you to deal with the situations? And facilitate the development of means for the client to cope with situations based again on evidence-based practice. I'm gonna let this last person in, and go ahead, Joe. So in order to develop harm reduction, what we need to do is change the way that we're thinking. And that's what we mean by a paradigm shift. We need to move to non-judgmental, person-centered language rather than language that's stigmatizing. We need to help the patient set goals and to reach those goals as a team. We need to help them to heal, not decide what's right for them. And we need to, and the big thing here is we need to rethink what our goal is, that the goal should be giving the patient quality of life, not necessarily cessation or abstinence. And those are very big changes. Go ahead, Joe. So when we look at harm reduction, it's non-judgmental and it is holistic. We look at the patient as more than just the substance use disorder, just like we look at somebody with a glucose regulation problem as more than just a diabetic. There's more experiences in their life, there's more background in their life that we need to know about, and there are very definitely underlying causes that we need to talk about. Those causes involve life circumstances. Are they living in dilapidated housing? Do they have housing insecurity? Do they have health problems other than related to substance use? And most importantly, are they suffering or have they suffered adverse childhood experiences? And I assume most people are familiar with this notion, but adverse childhood experiences is a really scary concept when we look at the fact that, next slide, Joe, 67%, yep, of the population has had at least one major adverse childhood experience. And that's an awful lot. 2/3 of all people have had a major adverse childhood experience. And that could range from anything from divorce, death of a parent, parent leaving home, parent being incarcerated, parent being mentally ill. It could be abuse, physically, emotionally, sexually. It could be neglect. But 67%, 2 out of 3 people have had at least one adverse childhood experience. I just always find that statistic incredibly scary. And as you can see from the pyramid, adverse childhood experiences very definitely have effects throughout life. They can lead to anything from cognitive impairment through disabilities, through death, and obviously all very big problems. Go, Joe. Anybody have any questions or thoughts yet? I just hate the dead silence. Everybody's still alive out there. Anybody's still alive out there? Joe, you still alive? No?
I am sorry. Moving over to the mute button instead of pressing the space bar is difficult. You guys can use the chat function if you'd like.
I told them that, but they don't talk to me. So what we got is harm reduction is healing, not paternalism. What that means is not telling the client, we know what's best for you, not telling the client how to get better, not making decisions for the client, failing to tell the patient what the options are, failing to explain things to the patient, being annoyed when the patient or client doesn't stick to treatment and come back again. Those are all the things we want to avoid. What harm reduction is exploring underlying issues and working with the client, exploring the client's goals and helping them to find ways to achieve those goals, respecting the client, and recognizing that they need quality of life, not abstinence. Next. So the aim of harm reduction is to improve the quality of life. Did we skip a slide? Yeah, we skipped that slide, right? Okay, so the aim of harm reduction is to improve the quality of life, help the patient reach their goals or move toward their goals, and have the patient come back for further treatment and continue to work with you. Next. Now, when we talk about harm reduction, we're talking about harm reduction, not just for the clients, but for the practitioners as well. And that means avoiding burnout, because burnout is a major problem in all of the fields that we work in, whether psychology, social work, behavioral health, nursing, that obviously we all have incredibly high patient volumes. We all have incredible workloads. And if you look back over the course of the last couple of decades, patient volumes and workloads have gotten much bigger. The time that we need to address all of the issues that we deal with, including substance use disorders, is just remarkable, and 24/7 just doesn't seem like enough. We need ways to help manage our work and community commitments, again, 24/7, and you're doing everything both in your personal life and in your work life and trying to fit everything in, and just seems like the day is never long enough. And some people work, unfortunately, in very negative work environments. We're likely to develop burnout because we witness a lot of traumatic situations. We witness people who are harmed by violence, by death, by choices that they make, by poverty, by punitive systems. And all of these things can cause burnout, which lead to emotional exhaustion, depersonalization, and a lower sense of accomplishment. And we know that when you're really stressed and overworked, you just feel like nothing is going right or nothing is getting done the way that it should. Next. What we need to do is recognize that these symptoms of burnout that we feel are indicators that something is going on and that we need to address those indicators. We need to recognize the symptoms and address them rather than avoid them. And that means taking care of ourselves. And that may mean does mean maintaining a rich life outside of work, seeking help from others if we need it, seeking social support, and disclosing if we're traumatized. Go ahead. And by doing that, we can cut down on our burnout. And if we cut down on our burnout, then we can more successfully help ourselves and the client. So when we're dealing with harm reduction, one of the big things that we need to do is use person-centered language. Again, avoiding stigma in language, referring to people as people with a substance use disorder is a lot less stigmatizing than referring to someone as a substance abuser. If you use the terms substance abuser, addict, alcoholic, junkie, those are all negative terms and have very stigmatizing effects on the clients. Individuals who think they are stigmatized also have lower functional outcomes, lower self-esteem, less recovery capital, and show some of the same effects as the people suffering from burnout. So in order to use more patient-centered language, go ahead, Joe. The Institute for Healthcare Improvement has started a Recover Hope campaign, Change the Narrative pledge, that encourages people to use person-first recovery-focused language. And that means that we will talk about people with substance use disorders rather than drug users, abusers, alcoholics, junkies, addicts. We will talk about the existence of a substance use disorder rather than a drug habit. We will talk about substance use or misuse rather than abuse. And we will talk about risky or unhealthy behaviors rather than people having a problem. My favorite still, and Joe was tired of hearing this because I harp on it, is that a person is clean. And I'm going to ask somebody to unmute themselves and pretend and demonstrate that they are alive out there. What is the problem with saying a person is clean? How is that stigmatizing?
Because if they're using, it would imply that they're dirty.
Right. The opposite of clean, obviously, thank you, is dirty. And by inferring that a person can be dirty, that is indeed stigmatizing. So we should not be talking about people being clean. We should be talking about people not currently using substances, possibly currently being abstinent or in recovery. We should not talk about the existence of relapse, but rather a return to use or a recurrence of the substance use disorder. We already said clean or dirty, bad things. What we should talk about instead is the blood test results or urine test results, positive or negative. And even substitution or replacement therapy is now kind of frowned upon, that what we're looking at instead is treatment for a substance use disorder. And rather than talking about MAT, medication-assisted treatment, we now talk about MOUD, medication for opioid use disorders. We are using medications to treat disorders just like we would people with any other kind of disability or illness. Go ahead, Joe. So looking at language, and again, I'm going to ask somebody to be bold and unmute themselves. We have two patient assessments. Ms. J is a 44-year-old female with a long history of polysubstance abuse with poor compliance with outpatient treatment and little insight into her addiction, who presents complaining of pain and swelling of her right lower extremity. She also has a history of drug-seeking behavior. I suspect this and homelessness are the primary reasons for her visit, i.e. secondary gain. So, where's our bold people now? What's wrong with this assessment? There's a lot wrong with it, but like what? Anybody see any problems with it?
I mean, the summary doesn't address anything about her actual presenting complaint of pain and swelling.
Right. We're ignoring her complaint. We're doing exactly what Stephanie said in the video there. We're looking at her as a person with a long history of polysubstance abuse. We're looking at somebody who has not really complied with outpatient treatment for addiction in the past. We're looking at someone with a long history of drug-seeking behavior. And then we suspect that homelessness rather than home insecurity or housing insecurity and drug use are the primary reasons for her visit. We're totally ignoring the fact that she's there for pain and swelling in her right lower extremity. If she were there with a broken leg, we would be doing the same thing. Her description would be the same, complaining of, a broken right thigh. We're looking at not what her complaint is, but we're looking instead at all of her past problems. Carlene?
Just the word compliance.
Poor compliance.
That compliance or non-compliance for me is just a word that,
yeah. So it says that she could be doing things and she's not, and we should not really be using that term. This basically says that, she's,
okay.
That what she's doing is not okay. So what could we have said that would have been better? Go ahead, Joe. So now Ms. J is a 44-year-old female with a past medical history of substance use, better than long history of polysubstance abuse, who presents with pain and swelling in her right lower extremity. She's been previously lost to follow-up rather than non-compliant in outpatient treatment, possibly due to housing insecurity. So while this is still acknowledging that she does have a past history, that she has been in the system before, that she has other problems as well, but it is not looking at this and saying she's here just for drugs and that she's flunked out of the system before. So go ahead. So obviously language makes a difference. Back up for a second. I know I just told you to go ahead. Something that I just always want to throw in, and this is just from past experience, and I'm never sure where to throw it in, but sort of one thing that I always say to family members or even to patients when they come in, if you're back in the days when if you were in the emergency room or in a hospital, you could have a visitor with you, pre-COVID. I would see family members just there with their son, daughter, husband, spouse, who had suffered from an overdose and looked kind of awful. And I'd see staff members, people that I worked with, coming in and looking at them as if sort of, almost the scum of the earth. And obviously that should never have been there, but people react that way. And I've said to that mother, father, spouse, if you have a picture of your husband, son, daughter on a good day, just take out that picture and put it next to them, because to a lot of people, including unfortunately a lot of people I worked with, just seeing that, oh my, this is not how this person normally looks, that this is your mother or your father or your brother, and seeing them as a real person can also make a very big difference. Carlene?
What a great idea. Yeah.
It's just something that I always found worked. And I can never figure out where to throw that in, so it just pops up wherever I think of it. Okay, go ahead, Joe. Okay, so now what we're going to do is look at several harm reduction interventions that have been used in this country and throughout the world. Some we're more familiar with than others. Naloxone or Narcan, constantly in the news as first responders are using it more and more to save people from overdoses. Should be in the news more and more as we talk a little bit later about the status of overdoses and overdose prevention in Rhode Island. Syringe exchanges, needle exchanges appeared first in Europe and are now much more prevalent in this country than they ever were in the past. Fentanyl test strips are sort of newer on the scene and familiar to some of you and unfamiliar to a lot of you, but making a very big difference in terms of overdose prevention. Obviously, we can counsel people on safer using practices. And then finally, overdose prevention centers, which are now becoming widely available throughout Europe, but are still sort of non-existent here, but are looking at becoming existent here. So go ahead, Joe. Starting with Narcan, naloxone. I assume this is something that most people are familiar with, but just sort of the overall overview. An opioid antagonist, namely referred to as Narcan, its brand name. But opioid antagonist means that this is basically something that will go to the opioid receptors in the brain. And if there is an opioid attached at a site, it will kick it loose and take its place so that that opioid can no longer have an effect. What that means is this reverses central nervous system and respiratory depression, that it is available to be given both intranasally and intramuscularly, different doses available for different ways of giving them, that it is covered by a standing prescription in Rhode Island so that anybody can have Narcan available to them, and it is covered by Medicaid and most prescription coverage. It is not habit forming. It does not lead to an increase in opioid use. And more importantly, and I don't know why this is never in here, but it is something that will not do other harm. It has no effect other than kicking that opioid loose from the receptor site in the brain. If you stumble upon somebody as you're walking down the street who has collapsed and is now on the ground and you have no idea what happened to them, if you look at somebody, first responders come along to a car accident, and this keeps happening all the time now. We keep hearing it in the news in Rhode Island in particular. There's a car accident, a guy hits a pole and is unresponsive at the wheel when the first responders get there. There's a baby in a car seat in the back seat. And the question is, what happened? Did he black out and hit the pole? Did he fall asleep and hit the pole? Did he have a medical emergency? And if so, was it substance use? Did he have a heart attack or a stroke? And obviously, one thing you could do is give him Narcan. If he did indeed respond to substance use, if this was an overdose, then the Narcan will have an effect. And sometimes it needs to be given more than once. And by the way, I always do say for people who aren't familiar with Narcan, if you do give it, then you want to give it and sort of back away very quickly, because as people wake up from this overdose, what you've done is taken away their high. They were feeling quite good, even though they were feeling quite nothing. And now you're making them feel horrible, and they will indeed strike out at you. So sort of give it and back up, because they're gonna go for you if they can. Now, if they did have a heart attack, if this is a hypoglycemic episode, if they had a stroke, you've done nothing wrong by giving them Narcan, because it took, literally seconds. And if it works, it works. If it doesn't work, it doesn't do anything else. So, you could still implement CPR. You could still check their blood sugar levels if you're an EMT. But Narcan is sort of always a good starting point. what that big paragraph at the end there says is that in communities where Narcan is used, even if it's used just a little bit, as compared to communities where it's used a lot, in either case, Narcan use tremendously decreases the number of overdose deaths compared to communities where it's not used. So what we want to do is foster the use of Narcan. And I think I harp on this a little bit too much too, but I do it anyway because I feel like it's important. That how many people, or just sort of like show of hands in the box, anything, have been Narcan trained or carry Narcan with them? How many people have not? So Aaron, is that a yes, you have, or a no, you haven't? Yes, you have?
I have been trained in the sense that I've seen a slide like this before, but I've never actually like held it.
Okay. So for people, and because apparently a whole lot of people are aware of Narcan and know how it works and know what it does, but have not actually had Narcan training. And I just want to throw in there, and Joe will reiterate later, I think, that Narcan training is something that is readily available in Rhode Island. There is a great program that Joe is involved with. It's called PONY, Preventing Overdose by Naloxone Intervention. And they're amazing. They go out anywhere. They'll come out to the colleges. They'll come out, and having taught at Rick, they did Narcan training there on a regular basis, either in certain classes or for student community government or even for the faculty. And it's just a really quick, usually like half-hour training where they teach you everything that Narcan does and doesn't do, how it can be given, how it should be used. And once you've had that training, you can actually, you're given Narcan, and once you get it, it's good for a year, and it can be renewed, you know, on a yearly basis. You can get basically retrained or get another prescription for it. And one of the things that I think is just that for harm reduction, one of the best things in the world that we could all do is get Narcan training. I really think the nurse in me thinks that this is akin to doing CPR. And I have gigantic fights with people, most notably my husband, and I won't talk too loud because he's around here somewhere. But every time we do Narcan training, I basically say, you should get trained. And he's like, why? I don't know anybody who uses drugs, and therefore I don't need it. And I'm like, number one, you don't know if you know anybody who uses drugs. And number two, you learned CPR because somebody might have a heart attack, whether it's somebody you know or not. And he and I have walked down the street and done CPR on, you know, an older person who was walking down the street with his wife and clutched his chest and fell to the ground. And I was like, you did not know you were going to need the CPR, but you used it and you saved that guy's life. And equally easy, or even easier to do with Narcan when we're dealing with overdose. So something that I feel like really strongly about that people should do. Okay, next, Joe, I'm sorry. Okay, when we look at syringe or needle exchanges, these have been very widely used in Europe, and they are very, very effective in stemming the spread of diseases, Hep B, Hep C, HIV. They are incredibly cost effective. For every dollar that's spent on a needle exchange, $6 is saved in HIV or AIDS treatment. It leads to increased enrollment in substance use treatment programs. It does not lead to increased use. Again, these were the parents of the elementary school kids who said, don't tell them about condoms, it'll only make them sexually active. Don't tell them that they can get clean needles because that'll make them use. No, not likely. What it's going to do is allow them to use more safely. And syringe and needle exchanges are very widely supported now by the World Health Organization and the American Medical Association. Go ahead, Joe. So In Rhode Island, we have a lot of syringe exchanges and needle exchanges popping up. Encore, AIDS Care, Ocean State Needle Exchange, which is in Providence, but reaches out to Pawtucket, Woonsocket, and Newport, Project Weber Renew, Serenity Center, and all of these will provide free needles, free clean needles, syringes, Narcan, fentanyl test strips, cookers, which you'll need to use with your fentanyl test strips, and sterile supplies, as well as condoms. I always think that's interesting that they threw that in there as well. Go ahead, Joe. So, fentanyl test strips. Are there people out there that are not familiar with these? They haven't been on the market or on the scene that long, so I would suspect that there are people who have not yet encountered them. But I think most people know that one of the reasons that we're seeing so many overdoses these days is because the drugs that people are using are not pure. They are tainted with very different substances. And one of the substances that has been added to many, many drugs like heroin is fentanyl, which again, always boggles my mind, because the first time I encountered fentanyl, it was in the newborn intensive care unit, and we used it to treat very premature and sick newborns who were suffering from pain. And it was a great painkiller. And I never thought about it being a problem, but clearly what we used there were tiny doses. We knew where it was from. We knew how it was made. We knew the strength of it. So it wasn't a problem. The reason it's a problem now is because people, number one, don't know it's there. So when you're adding it to heroin and they think the heroin is a certain strength that they're used to, and now it's got fentanyl in it, it's much stronger than anything they've ever used before. It's not pure. They don't know where it came from. It can have anything in it that can just be really detrimental and cause overdoses. Now, fentanyl test strips, which are given out at these needle and syringe exchange centers and at the safe use centers, are very specific. They allow you to find out if the substance that you're using is tainted with fentanyl. And basically all you would do is take sterile water, add it to whatever cooker you were using or whatever empty bag that had residue in it. You would mix it together and then insert your test strip into that now mixed water. And it is truly like a pregnancy test. It gives you, if you look at step 4 there, it gives you lines that tell you, one line positive for fentanyl, 2 lines use caution. 2 lines means fentanyl does not appear to be present, but. Now, number one, it is indeed like a pregnancy test, because sometimes if you've ever looked at pregnancy tests, some of the lines are sort of vague. Gee, is there a line there or is there not a line there? If there's a vague line there, there's a line there. So you don't show up as vaguely pregnant. You're either pregnant or you're not. There's either fentanyl in this or not. If there's a single line, even if it's a vague line, there's fentanyl, and beware. And if you get the double line, it says there's not fentanyl, but use with caution, because that doesn't mean that there's not other bad stuff in it. If patients know, and fentanyl test strips are very, very sensitive and very specific. They'll pick up like 96% of the cases that do include fentanyl, and they are specific only to fentanyl. If patients know that there is fentanyl in what they're using, number one, they may not use it at all. They hopefully will use it more slowly. They won't use it without other people present. And one of the things that we typically talk about doing when we talk about counseling people for safe use is don't use alone, because if you're not alone, then if there's a problem, somebody will be able to realize it and get you help. If you're alone, big problem. Make sure that you or somebody around you has Narcan, and you might want to think about where you're getting your drugs from, because if they're tainted, then you should not be getting them from the person you're getting them from. or maybe they'll stop using altogether. So fentanyl test strips, very good thing. Go ahead. Safe injection practices, counseling people as to what's safe, you know, and again, nursing, psychology, social work, otherwise behavioral health. You want to make sure that you're in a nice, warm, clean environment, that you're getting good nutrition and adequate hydration, that you're getting enough sleep and medical care, that you're cleaning your sites safely, and that you're rotating your sites. Even, you know, again, if we're looking at somebody with a glucose control disorder who uses insulin, they don't give the insulin in the same spot every day because that would lead to long-term problems. So what you want to do is rotate the injection sites and always use new needles and new syringes. Go ahead, Joe. Overdose prevention centers, very interesting concept. Also known as safe consumption sites, supervised injection sites, safe injection sites, medically supervised injection centers. Again, very widely used now in Europe, very rarely seen in the United States, although we're asking for them, so we suspect those pop up shortly. But they give people a nice, clean, safe environment in which they can use drugs, substances that they have gotten in the past, whether recreationally or otherwise. And they can use these substances in that safe environment with medical supervision present. As I said, this is not yet available in this country, but we expect to see it shortly. Sort of interesting idea again. Go ahead, Joe. So how do we integrate harm reduction into practice? Go ahead. So we can do it with a number of different ways. We need to do it holistically so that we're addressing the patient's needs. We need to think about them with empathy and respect. We need to include all patients without thinking about them in a stigmatizing or discriminating way, using no judgments. And we should be basing our strategies on evidence-based practices that have been shown to work. Go ahead. So in order to integrate harm reduction into practice, you can create a relationship to ensure the patient is comfortable talking about substance use. Now, the thing that this skips is you need to be comfortable talking about substance use. Too many professionals, whether doctors, nurses, psychologists, social workers, are just not really comfortable talking about substance use or asking questions about substance use, in large part because they're not sure what to do with it when they get the answer. If I ask a client about substance use and they tell me, yes, they are using and what they're doing, now what do I do with them? You need to know, not just, okay, I asked the question, good, now I know that you're in a bad scene. I need to know what's available to you, and I need to make those resources available to you. And I need to create a safe environment in which you can talk about the things that are important to you. And all of that includes putting out flyers and displaying various kinds of harm reduction tools. Go ahead, Joe. So how will you implement harm reduction techniques into your practice? Now, Joe is going to do a sneaky little thing, I believe, and separate us. There are 15 of us in this session. And Joe is going to break us up into little breakout groups, and you can talk amongst yourself about what you could do or what people in general could do about implementing harm reduction techniques in your everyday life and your everyday practice. So go for it, Joe.
All right.
And then we'll come back and let you report out.
Okay. So I'm going to stop sharing for a second so I can get everything ready. And we will be doing this for, would you say 5 minutes? Did you say 5 minutes?
I don't know if I said it, but yes, 5 minutes.
Okay. There will be a invitation for you to join your groups. So accept that when it's up, and then there's going to be a timer that will count down the 30 seconds before you rejoin us. You can wait until that 30 seconds is up, or you can rejoin right away. All right, so I'm going to open all the rooms now. Jennifer, are you having any trouble getting into your breakout room? Hi, are you having trouble getting into your breakout room?
I saw a really good hamburger, well, not a hamburger, Ash.
Oh, you're on mute again.
Can you hear me now?
Yep, I'm able to. Are you able to join your breakout group?
I'm not sure. I think I might have pressed not now, an accident.
Okay. Let me see if I can get you in. Oh, whoops. Okay, I'm gonna move you to a different breakout room. And it should, did you get the invitation? Do you see the invitation? We're just waiting for, oh, never mind.
Are we all back? Are any of us back?
It was very cool.
Everybody's back.
Okay. So hopefully people had good sessions. I found out other people could talk and I could still hear. I was very excited. Okay, so anybody bold out there who wants to report back on what your group had to say? Don't all volunteer? Okay, Carly.
Who, me? Carlene?
Yeah.
I think our group all introduced each other, and so we all understood where we all coming from. But I think we were at the very beginning, it was a very quick meeting.
Yeah.
We're all understanding that this is work that we need to do. But I think we're at the beginning of understanding that we all need to do this work, but we are really at the foundation level of knowing what we need to do.
Right. Anybody else? Esperanza?
This is Christine. I was in the same group with Carlene, and I'd just say that to echo what she said, that I think having just a solid foundation and making sure you're using the right language in how you're talking with individuals is just such an important step in being able to then use more advanced techniques. So.
Okay, good. Esperanza, I'll pick on you because you're at Rick.
Well, I'll only speak. I know we had other two participants in our group, but I just shared that at Rhode Island College, we started a new kind of strategy with nursing students where we have the Rhode Island disaster management team come once a semester and provide a 1-hour training to our students on administering Narcan and, assessing for signs and symptoms of overdose and things like that. And we've had a great response to that. So we capture about 160 students a year with that sort of training because we incorporated it into a nursing course. So we just started that last semester.
Good. And Alyssa, can you just tell us what you said you guys are doing with the professionals in psych?
Yeah, well, not just the professionals in psych, but we have interdisciplinary meetings where we huddle with the medical providers and normally on different topics. And so it was a possible plan to bring this in as the next topic we go over with them, and sort of documentation and referral and role playing how they talk about it all.
Good. Any other groups? I can't pick on the rest of you. I don't know which groups you were in. Any other takers?
In our group, 2 of us were in research, so we talked about how we can use these harm reduction ideas as outcome measures in our research. But then also we had a few folks who do work in hospital settings, and they were able to give some examples where they've seen people who come in with substance use issues be kind of stigmatized, like in a medical setting. So it definitely highlighted the importance of importance of this work.
Yeah, good. All right, so that sounds great. Sounds like some productive stuff out there. And yeah, just working in the field, and every time I remember this, it just makes me crazy, because working in the NICU, we did get any number of babies that were born to mothers that had substance use disorders. And a fair number of them were mothers that had been in treatment, that back in the day were on methadone or Suboxone, and staff would come in and literally react to them as negatively and as stigmatizingly as mothers that had no treatment at all. It's like they just substituted one drug for another. They're still just a junkie. And it makes me completely crazy. And it just took a whole lot of education to get them to change their ideas. And now we got to get the rest of the world to change ideas too. Okay, go ahead, Joe. Joe. Ah, there you are. So when we look at substance use, we need to talk about what substances are and how and where they're used, because clearly there are substances that are acceptable. Caffeine, for those of you that are having your early morning coffee, sugar, alcohol, it's 5 o'clock somewhere, or COVID time everywhere. The areas that are sometimes acceptable and sometimes not: nicotine, cannabis, and is it recreational? Is it for your glaucoma or for your nausea with cancer? Prescription drugs, and are they being taken as prescribed or for other reasons and not how they're prescribed? And then things like the illegal drugs, the cocaine, the heroin, the methamphetamines that we always consider to be basically unacceptable. But even when you look at the acceptable ones, the question is, how and when are they being used? Go ahead, Joe. So a man's taking a plane trip and is terrified of flying. He takes some of his partner's prescription Klonopin before getting on the plane and stays calm throughout the flight. The medication has worn off by the time they land. Is that okay or not okay? And why? Anyone? Okay, I'm going to go with it's not okay. Can somebody tell me why?
Well, can I respond?
Absolutely, please do, Carlene.
As a clinician, I would say it's not okay, because he could be on other medications that could interact with that medication without him even knowing it, just pure and simply.
Absolutely. And even if he's on no other medications, it's not okay, because what should he have done?
Called his own physician and asked.
Yeah. If I'm terrified of flying and I know I have to fly, help, give me something to deal with it. But how many people do we know that will take, mom's Xanax or a friend's, Ativan or whatever? Let's just do it. Okay, so clearly this is not a good thing.
I think I'm wondering if that speaks to stigma about having any anxiety of any kind or any.
Yeah, probably. We just don't want to admit to somebody that we need help. And that's one of the things that we need to do, is get used to asking for help in any area. Too many of us just won't do that. Go ahead. So when we look at what's acceptable, is it okay to have a cup of coffee? Sure. Although I have to tell you, when I worked in the NICU and we used to give the babies IV caffeine to get them to, stop having apneas, to keep breathing, we used to sort of line up and think, gee, if only there were a way for us to do that, but that wouldn't be acceptable. That, alcohol, are you having the occasional social drink, or are you doing binge drinking in college or any place else? Prescription drugs, are you taking them for pain control, or are you just using them recreationally or because you've gotten used to taking them? Nicotine, are you smoking or vaping or using a nicotine patch? Marijuana, is it for pain or glaucoma or recreationally again? And then, the usual misuse prescriptions. How many students use Adderall or other ADHD meds to help them to study for exams? So, some meds that are okay some of the time are not okay in other circumstances. Go ahead, Joe. Now, when we look at substance use, we need to clarify what is substance use and what is a substance use disorder, because they're very different things. And again, we said that the sort of definition of those things has changed in the last decade or so. Substance use is using substances that does not reach the threshold of a disorder. It may be recreational use. It is not a serious health problem. It is not a disorder. And it is not the same thing as drug abuse or addiction. Go ahead. Substance use disorders are very different things. Now, this slide is a little bit weird and noisy and busy, but it's also based on DSM-4, the Diagnostic and Statistical Manual of the American Psychiatric Association, 4th edition. And that has been replaced by DSM-5. But just looking at this slide sort of quickly, what you see is they list various substances from nicotine through alcohol and stimulants, and look at the proportion of time that people are using them and the percentage of people who develop chemical dependencies or substance use disorders. So when you look at the green part, the chartreuse color there, those are people who are substance users. If you look at the orange part, those are people who have substance use disorders or misuse. So we're looking at, more people with substance use disorders using nicotine than cocaine, but we're also looking at large numbers of people who do use substances but have not yet reached substance use disorder. DSM-5 has changed how they categorize substance use disorders, and that sort of makes this a little bit clearer, a lot clearer, I think. So if you flip to the next slide. So DSM-5 looks at substance use disorders as essentially a continuum. You can have 11 different symptoms, criteria of substance use disorders. And if you have 2 or more of them, then you are categorized as having a substance use disorder. And then they're broken down into mild, moderate, or severe. But we're looking at the characteristics as, is this use hazardous to you? Is this interfering with your social or personal lives? Is it causing problems for you? Are you neglecting your roles to use it? Are you missing work? Are you missing meetings? Are you skipping out on appointments with friends? Are you suffering from withdrawal if you're not using it? Are you developing a tolerance so that you need more and more of the substance for it to have the same effect? Are you using larger amounts for longer? Have you tried to stop using it and keep coming back to it? Are you spending a lot of time using the substances? Are you developing physical or psychological problems? Are you giving up activities to use this? And are you craving the substance when you don't have it? Now, if you flip to the next slide, DSM-5 will tell you that if you have 2 or 3 of these criteria, you have a mild substance use disorder. If you have 4 or 5 of them, then you have a moderate disorder. If you have 6 or more, then this is a severe disorder. And 6 out of 11 is not really a lot. If you have 1 or fewer, then that is characterized as substance use and not a disorder. So just flip back to the last slide for a second, Joe. So looking at them again, 1 or 2 of these, one of these would be no disorder. 2 or 3 of these would be a mild disorder. 3 or 4, a moderate disorder, and 5 or more, then a severe disorder. So if you, for instance, felt like you were interfering with your personal relationships, if you felt withdrawal symptoms when you were not using, if you were using more and more to have the same effect, if you were using more time and craving, that would be 5, you would have a severe substance use disorder. Okay, jump slide to the one after next. Okay, so that brings us to COVID-19 and the opioid epidemic. And oh God, what does one say about that? COVID-19 and anything is obviously a gigantic problem. I am going to pull up my cell phone for a minute and look at a picture that I took of a news clip that was on Sunday, I believe, on WJAR. And this was just a clip that involved Dr. Nicole Alexander Scott, the state director of the Department of Health, who said the drug overdose crisis is worse now than it's ever been. She said the state's on track to have 25% more overdose than 2016, which was Rhode Island's last peak. So yeah, for 25% more deaths than we did at our high. There were 233 accidental overdose deaths between January and July, 185 last year. So they think that stress and isolation from the COVID-19 pandemic is a driving factor in the spike, as well as the number of counterfeit pills being sold on the street, and said that everyone can play a role in helping to curb overdose deaths. And that's where the harm reduction comes in again. But I was just like, oh, go Nicole. But it's just so awful that, you know, we had the opioid epidemic to deal with in the first place. COVID-19 is, I think, stressful for every one of us. I don't think there's any one of us that hasn't had the effects of it. And you just put that together with the opioid epidemic, and it is so hard for substance users to deal with the issues. We need to find better ways to reach those who have opioid use disorders or who have substance use disorders. And there are things available out there, but they're still really problematic for a lot of these people. What we find is, okay, number one, that phone number there, really important. Hotline, 401-606-5456. And that is the Buprenorphine Induction Hotline. I don't know how many people are familiar with it, but that is a number that a person with a substance use disorder could call and speak to a clinician and literally get into a program and get buprenorphine right off the bat. So that is something that's available to people. But again, like people said in the breakout rooms, you need to know it's there. And we just don't know these things are available out there. That because of the COVID epidemic, that we've changed the policies on treatment of opioid use disorders so that we're sort of allowing more people to take meds home with them than we might have in the past, earlier than we would have in the past. And that's sort of necessary because people can't come into treatment programs the way that they could in the past. They're afraid to go to the hospital. They don't have access to recovery resources. Go to the next slide. So what we find is COVID-19 is a problem for everybody. Clearly, we are doing what we're doing today as a Zoom instead of in person somewhere because we can't meet in person. Well, we have access to Zoom. We have access to computers and smartphones, but not all people with substance use disorders have that access. That because of that, people are being allowed to take treatment drugs, medications for opioid use disorders home before they're ready to. They may not be able to go to in-person support groups anymore, and that's really negative for a lot of people and makes them feel really isolated. And that leads to an increase in recurrences. Go ahead. Ooh, Abby. That brought us all the way to Abby. Okay, so I don't know how many people are familiar with Abby Stenberg, but she's a very well-known individual in the state of Rhode Island in the area of substance use. She's a person who, as she will tell you in here, had a substance use disorder and literally now is in recovery from it and is working in the field. Go ahead, Joe.
Every single community has been affected, every demographic, every type of person, you know, men, women, young, old, black, white, doesn't matter. I am a contributing member of society today because naloxone was in the hands of a layperson. I had just experienced 3 overdoses a few months prior to that, and I was just hopeless, scared, 22, no clue how to live my life. All I had really done up to that point was use drugs and find ways and means to get more. Little did I know, just on the other side of that door was an entire community wanting to help me. Our community has shown up in a real way. I always say that.
Uh-oh.
I'm sorry, I don't know what happened or how to get to the end. I can probably do it verbatim at this point. So she just finishes up by saying it's all our responsibility to have naloxone and Narcan and administer it. I think it's a really great video, and I'm sorry that it has ended prematurely. I can send out the link if anybody's interested.
And also there is, if you get the link, there is a much longer video, like 10 minutes, not really long, that in which Abby actually talks about how she got to where she is in recovery today and what she does. She worked first as a recovery coach, which we haven't mentioned those, but are an important thing in harm reduction, because these are people who literally will show up in the hospital, will be called in and come to you in the hospital, and people who know the system and will help you navigate through the system. Really good thing. But the other thing that I wanted to say that I always want to throw in here is just Abby says she overdosed 3 times before she got to where she is today. And if you look at other people, and I don't know if the people at RIC are familiar with this or not, and this is somebody who always tells her own story, so I can do it. I had a student as an undergraduate who's now getting her master's and will then go on for a doctorate and work in the field of substance use disorders, who is in her very early 30s, and at a Narcan training that I was at a couple of years ago, said, I just want people to know that by the time I was 22 years old, I had overdosed 29 times. And I wish you were unmuted so I could hear all the gasps, because 29 times is absolutely incredible. And these were all accidental overdoses. And people time and time again said to her, you know, like, if you just want to die, then just die. Like, why do you keep doing this? And she's like, I'm not trying to die. These are not suicide attempts. These are accidental overdose. And people are like, you know, why keep bothering with the same person over and over again? Well, after 29 times, she decided that this was not the way that she wanted to live her life, and has not used any substances. I will not say has been clean, has not used any substances for the last 8 years, is now married, working on her master's and then doctorate, has 2 children, and is very actively working in the field of substance use disorder treatment. So the big thing is, if we can reduce the harm, if we can reduce the stigma and allow people to use substances more safely until they are ready to make other changes, then we're saving lives and making a giant difference in the world. Just one other thing I want to throw in, and I know I left no time for questions as always, but another picture on my phone, if I can find it, was that very same person who had overdosed 29 times, posted on Facebook, hello friends, a journalism student, and this is just yesterday, a journalism student reached out to me and is looking for someone to give her their story. I cannot even begin to tell you how important our personal experiences are. If you feel like sharing, here is what she's looking for. And the journalism student said, hi everyone, my name is Gaia Gupta and I'm a journalism student at Brown writing about Rhode Island's Good Samaritan law, which protects people from being charged with drug offenses if they call 911 during a drug overdose. If you or someone you know has overdosed but felt too scared to call 911 despite this law, or if you know someone who's been charged with a crime because they called 911 during an overdose, I'd love to talk to you. So if anybody sort of is interested in that, we can give you a link to that as well.